Hello, everybody. Welcome to our first World Bronchiectasis Day webinar. I'm Amy Liebman, President of NTM Info Research. I will be your co-moderator for today. We're very pleased to present this webinar along with Running on Air. And we're very pleased to welcome our speakers, Mary Kitlowski and Dr. Ann O'Donnell. Thank you so much for joining us today from wherever you are around the world. Mary Kitlowski is president of Running on Air, and Dr. Ann O'Donnell is division chief of pulmonary medicine, critical care, and sleep medicine at MedStar Georgetown University Hospital. Today's topic is an update on bronchiectasis treatments, including new investigational therapies. For today's webinar, you can drop questions into the Q&A by typing them into the box and then hitting send. You can send anonymously by ticking that box at the bottom. The chat will also be open, so you can put questions in the chat and also your comments there. We'd like to thank our supporters, including Insmed. Without support from companies like them and from people like you, we could not continue to bring this fabulous programming to you, and it's been our pleasure to bring you this wonderful program today. Don't forget to join us for an upcoming webinar on Monday, August 29th, Building Assertiveness and Maintaining Relationships with Dr. Elizabeth Devon-Smith at 7 p.m. Eastern. And you can find us on social media on LinkedIn, Facebook, Instagram, and Twitter, and you can find all of our latest webinars and our past ones on our YouTube channel. I'd like to turn it over in a moment to Mary Kitlowski, president of Running on Air. Mary Kitlowski is a speaker and advocate for those with lung diseases and rare diseases. She founded Running on Air to raise awareness of supplemental oxygen issues as well as for lung and rare diseases. Mary is a runner at heart with a rare and progressive lung disease called primary ciliary dyskinesia, or PCD. These days, though, she walks, her lung capacity at 30%, and she requires supplemental oxygen and is a lung transplant candidate. She completed her first marathon, the New York Marathon, in November 2019 in 9 hours and 50 minutes while carrying her 6-pound portable oxygen concentrator. That was her first New York Marathon. I know for a fact that she's completed many others at varying distances throughout the years. Mary, welcome, thank you, and please take it away from here.
All right, thank you, Amy. So I just want to clarify that was the only marathon, but I've done other races, half marathons, so appreciate that. And I just want to express my gratitude to Amy and NTMIR. I reached out to Amy for if she wanted to partner with Running on Air for this webinar, as I consider NTMIR and Amy experts in doing some of these webinars, and she very graciously accepted, and appreciate that Amy and her team are you know helping with their platform to bring this webinar to life. So I have the pleasure of introducing Dr. Ann E. O'Donnell. She is a professor of medicine at Georgetown University and chief of the Division of Pulmonary Critical Care and Sleep Medicine at MedStar Georgetown University Hospital, as well as sorry, I always like trip over the Nehemiah and Naomi Cohen Chair in Pulmonary Disease Research. Having authored over 40 manuscripts, Dr. O'Donnell is an internationally recognized expert in bronchiectasis and respiratory infections. She has been a principal investigator on numerous clinical trials investigating new therapies for bronchiectasis and NTM infections. And she is also the medical advisor for Running on Air. Thank you, Dr. O'Donnell, for doing this webinar.
All right, great. Thank you so much, Mary and Amy and Helga, for inviting me to do this on behalf of Running on Air and on NTMIR. So let me start by sharing my screen. You'll stop. I don't know, Amy or Helga.
You should be able to override it.
Okay, there we go. Okay, so my job today is to give you about a 30-minute talk on treatments for bronchiectasis. I am going to, oops, why can't my slides advance? There we go. Sorry, hold on one sec. there we go. I did want to mention that I put in these disclosures because I have been involved, as was mentioned, in a number of clinical trials. I'm not here to favor any one over the other or any product over the one over the other, but just want to give you an idea that I have been involved with these various companies who are doing work in bronchiectasis and NTM lung infection. So my goal here is to give you an update on current treatments, particularly to highlight guidelines that are out there that we physicians should be using to help care for you, the patients. The guidelines are good, but you have to tailor the treatment plan to the individual patient, and I'm going to focus quite a bit on this. And I want to remind everybody, as I'm sure most patients know, that all of these treatments that we're going to talk about are considered to be quote unquote off-label, because we really don't have an approved treatment right now for bronchiectasis, but we hope to have one soon. Then I'm going to just spend a few minutes on the role of clinical trials in finding new therapies for bronchiectasis and to some extent for NTM infections, and just review some new therapeutic agents that are in the pipeline and hopefully close to being approved. So let me point out that there are several guidelines out there that cover the topic of bronchiectasis. The most recent is the one that's been published by the British Thoracic Society. It's quite a hefty document that really gives a great overview of both on evaluating the patient with bronchiectasis and many, many treatment options that the BTS recommends. Our colleagues in Europe have also published a guideline. There is a small guideline that's US centered, if you will, that was published in the journal Chest in 2018. And if any of you are taking care of children or adolescents with bronchiectasis, there is a very excellent guideline that was done in collaboration with the European Respiratory Society and the Australian, New Zealand experts in childhood bronchiectasis. So just some documents to let you know that we do have expert opinion, if you will, on dealing with the disease bronchiectasis. And just very quickly, and I know the members of the audience know this, but many things can cause the final product of bronchiectasis. So bronchiectasis is the anatomic damage to the small and sometimes larger airways in the lung. And that damage can spread out into the lung itself, causing disease surrounding those bronchial tubes and small bronchial airways. But many things lead to this disease. And as you can see here, it can be a prior infection. There can be a focal abnormality in your lung, even something like a foreign body that can cause focal localized bronchiectasis. You can get bronchiectasis because of a prior inflammation, pneumonia, chronic aspiration into your lungs from your GI system. Of course, there's genetic reasons for bronchiectasis. Patients with autoimmune diseases like rheumatoid arthritis, Sjogren's, inflammatory bowel disease can get bronchiectasis. And then there's a host of altered immune responses that patients may have that lead to the diagnosis of bronchiectasis. So either an overexuberant immune system that causes allergic bronchopulmonary aspergillosis, or an underperforming immune system like patients who have low immunoglobulin levels can get bronchiectasis. So, you know, I know there's many people on this webinar, and so you know that there's various things that can cause this. It does complicate, though, how we treat the patients. And so that's why I wanted to highlight these various etiologies for bronchiectasis. Now, some patients, and I'm sure patients will recognize this as a CT slice showing an area of bronchiectasis, mainly the left lung on the right side of the panel, and also a bit of bronchiectasis in the right middle lobe. This patient isn't really somebody who produces a lot of sputum, so it can be hard to get a specimen from a patient like this with relatively mild bronchiectasis. But a patient with this kind of bronchiectasis that has a lot of disease, this is in the lower lobes, including a little cavity down there in the left lower lobe, tends to be more of a sputum producer. So we consider it to be different phenotypes, if you will, within bronchiectasis. So different causes and then different presentations of the disease. And that some patients are kind of dry, have a dry cough, are really bothered by it, but don't produce a lot of sputum. And other patients are quite heavy sputum producers. So this is how I view the underlying tenets of how to treat patients with bronchiectasis. And number one, to me, I think the patients need education on the disease. I mean, the word itself doesn't roll off the tongue, bronchiectasis, right? That it's a rare disease. Patients need to understand that this is an abnormality of the anatomy of the airways, and then you get an infection of various types, often on top of those abnormal airways. Number two, for me, I need to understand, in talking with my patient, the impact of the disease on the patient. So how symptomatic they are, vis-a-vis what I just said about their cough, how frequently they have an exacerbation or a flare-up of their symptoms, because that's real important in deciding how to treat the patient. Then I need to understand the extent of disease in an objective way. So looking at their CT scan, measuring lung function like pulmonary function tests and other physiologic measures, 6-minute walk tests, to see how impactful the disease is on the patient. And finally, if I leave you with one message, it's really important to know what bacteria is in the patient's lung with bronchiectasis, because if we're going to use antibiotics, we really should be using a specific antibiotic as best we can, aimed on the bacterial organism that's in your lung. So I'm big on these diagrams and pictures. We have them in all our exam rooms to help, sort of visualize for the patient what this is. So again, you see on the right-hand side of the screen there what a normal lung looks like in a little cartoon, and what a bronchiectatic lung looks like, with dilated, enlarged airways. And some patients have like cystic disease in their lung, and you can see for yourself. I mean, this really, I think, helps understand the panels on the left, where the mucus is trapped in these airways because they're bigger than they should be. We all make mucus in our lungs, but if the mucus doesn't move out towards the main trachea, that mucus is a good breeding ground for bacterial infections. So we get into this situation where we have a vicious cycle of inflammation in the lungs that's characterized by cells that we call neutrophils. And neutrophils follow along after bacterial infection, but neutrophils in of themselves can cause more airway inflammation and destruction. And then you get into this vicious cycle, or on the left, or what we call now the vicious vortex, where that inflammation leads to more damage, leads to more abnormal mucus clearance, and that results in more bacterial infection. So we want to, when we're dealing with treatment of bronchiectasis, we want to work on breaking the cycle, this vicious cycle, if you will, so that we don't see more damage, we don't see more infection. So my notion is there's several goals to treating patients with bronchiectasis, and we want to share those goals with the patient. It's unlikely, that we cure this disease 100% in most patients. So really what we're trying to do is to reduce the number of exacerbations, because we know that patients that have frequent exacerbations actually have a worse outcome. We want to control the day-to-day symptoms, right? The cough, the mucus production. Some patients with bronchiectasis have that disturbing coughing up of blood, hemoptysis, and we really want to try to prevent or minimize that. We want to improve the patient's quality of life and preserve lung function, and ultimately patients can live longer with this disease. And then we want to, like I said, we want to try to reduce the number of times they have an exacerbation, but when the patient exacerbates, we want to have a good plan to deal with that right on the spot, so that we can, again, reduce the length of time that they have to take antibiotic for the exacerbation, reduce the duration of the exacerbation, and ultimately keep patients out of the hospital. So it's sort of a five-pronged approach. First, if there's an underlying disease that can be treated, an underlying disease that's causing the bronchiectasis, we'll want to treat that disease. And I'll tell you more about that in a second. The next step up is getting the patients onto an airway clearance regimen. This is either mechanical, exercise, and then we have a couple of pharmacologic agents that we use to help clear the airways. The next step up, we consider using anti-inflammatory treatments in patients who are either frequently flaring up or having a lot of symptoms. And finally, if patients are having 2 to 3 exacerbations or flare-ups each year, we really want to think about some sort of maintenance antibiotic strategy. And then we treat the exacerbations, as I mentioned, and sometimes eradicate with antibiotics the first isolation of a significant bacteria. So again, we're looking to break this vicious cycle of infection, inflammation, and more damage by taking this strategy for treatment. So if there is even though we talk about non-cystic fibrosis bronchiectasis, that's our focus, right? Sometimes we do find that patients have cystic fibrosis, even though they present at an older age. And so that's very key to know, because we have excellent treatments now to deal with the underlying mechanism of CF. Some patients have alpha-1 antitrypsin deficiency. That's very rare cause of bronchiectasis, but there is a treatment for that. And then there is the primary ciliary dyskinesia, which causes bronchiectasis. We don't yet have a specific treatment for PCD, but we're looking for one. Some patients have their bronchiectasis because they're deficient in their immunoglobulins. We have a treatment for that, so that's something that should be pursued if you have that. And then the other thing is autoimmune diseases. If that's the cause of your bronchiectasis, keeping the systemic disease under control actually probably does help the lung disease. And finally, if the patient is aspirating, right, spilling their GI, gastrointestinal contents into their lungs, we need to address that. Second step is airway clearance. And those who know me know I'm a big advocate of this. We think it not only helps reduce the day-to-day symptoms, the cough and mucus production, but probably has a good effect on the longer-term reduction of the vicious cycle. So the mucus is stuck in these small airways, and we want to try to mobilize it. So in the old days, and still done, of course, for young people with bronchiectasis, there was a lot of emphasis on doing this, what we call percussion and postural drainage. So cupping and clapping on the lungs, and then putting the patients into certain positions to help mobilize the secretions. There's probably still a role for this, particularly again in younger patients, but there are some issues with this. I mean, you have to have a partner to do this type of treatment. And sometimes this can cause more acid reflux. So putting yourself in the head down position can make the acid come out of your stomach more and into your lungs. And we do worry about that. Sometimes patients just don't tolerate this positional stuff because their oxygen level goes down. So we've moved on to interventions that patients can do by themselves, like huff coughing and these other things that I mentioned here. I don't have the time to go into all of these things, but I would refer you to this there's several websites, but there's a good Australian, New Zealand website called the Bronchiectasis Toolbox that has video demonstrations of all of these type techniques. Another thing, we have some mechanical devices, and I'm sure many of you are familiar with these, oscillatory or vibratory positive expiratory pressure devices, and then for some patients, the high frequency chest wall oscillating vest. But honestly, you know, a lot of patients just by walking and exercising and deep breathing can really huff up their mucus. We often recommend in patients who do have sticky, thick mucus that they consider using some sort of agent to thin the mucus. And right now in bronchiectasis, although the data is somewhat limited, we often recommend the use of what we call hypertonic saline. So sodium chloride that's kind of salty, that seems to thin the mucus and make it easier to expectorate. One thing that's, standard therapy in cystic fibrosis bronchiectasis is what's called DNAs. And unfortunately, that had a negative study in patients with non-CF disease. So we don't recommend that. So I'm sure many of you do these things and find them helpful. Not every patient really benefits from this, but it's worth giving it a try, I would say, for all patients. But there are issues with this. You have to be taught properly how to do these things. That takes quite a bit of time. You have to get into a sequence with these therapies. Got to learn how to clean the devices and maintain the devices and keep from getting infected. So, like I said, another way to get at airway clearance is to walk or to run, like Mary here, or to do what you can, get out and walk around the block for 10 minutes every day. Some patients really do benefit from a formal program of pulmonary rehabilitation, and there's some data that's been published to support that. So airway clearance comes in a lot of different forms, and you can do it yourself, and you don't need any fancy devices, just to walk and cough and try to take deep breaths to get the mucus cleared. So again, I see airway clearance as a mainstay of therapy. When patients have more frequent flare-ups, like 2 or 3 times a year, then we think about giving them some sort of anti-inflammatory treatment. And the most common one we use in the US is Macrolide, usually azithromycin. This is for patients with 2 to 3 exacerbations per year who do not have non-tuberculous mycobacterial infection. I want to emphasize this because we don't want to give just azithromycin to a patient that might have that infection and who could become resistant to azithromycin. So, but there are some patients with bronchiectasis that benefit from chronic use of azithromycin, usually 3 times a week, seeming to reduce the exacerbations. Another anti-inflammatory therapy that's commonly used in patients is inhaled corticosteroids. Again, another little take-home message from me about this is that you have to be really cautious about this. I'm talking about there's a whole panoply of inhaled corticosteroids that can be prescribed, but you have to really need it to keep on it. I spend a lot of time actually weaning patients off this unless they have a very asthmatic kind of component to their bronchiectasis, because this can promote infections, particularly non-tuberculous mycobacterial infections. And then the last step for most patients is considering whether they need long-term antibiotics. And I put this here just to show the types of bacteria that patients with bronchiectasis often have. In our US bronchiectasis registry, about 1/3 of patients have Pseudomonas. Many parts of the world, Haemophilus is a more common bacteria. Some patients have Staph aureus, and then there's other infections that patients get. In the US also, of course, non-tuberculous mycobacterium is very common in bronchiectasis patients, and you do need to know that. So I put this here so that you just see those names and you think to yourself, I really need to know what bacteria is in my sputum on a regular basis, and I need my physician to be checking these cultures because if I need to take an antibiotic, I want to take the right antibiotic that's aimed at this. So in patients who are 3 or more exacerbations per year and who have chronic Pseudomonas infection, we do often put them on an inhaled maintenance antibiotic. We struggle with this a little bit. It's not approved by any FDA or the European agencies yet. There are some issues with this. It takes time to do inhaled antibiotics. They can be very expensive and can be difficult to get your insurance company to cover it. And part of the reason for that is we've done a number of trials with taking antibiotics that have been available in either oral or intravenous form and put them into an inhaled formulation and tried it out on patients with bronchiectasis. So you can see this long list of antibiotics that have been repurposed and tried in patients with bronchiectasis. And unfortunately, we have not found a slam dunk, if you will, inhaled antibiotic that actually works and is safe and effective in patients with non-cystic fibrosis bronchiectasis. Of course, there is off-label, not approved by the FDA prescribing of these things, and some patients do benefit. So, you know, this is a part of the armamentarium for treating bronchiectasis, but done very cautiously. So sometimes patients are faced with this: should I go on a chronic macrolide, azithromycin, or should I go on an inhaled antibiotic? And there's reasons to think about using a macrolide if the patient doesn't have a reason not to take it. But we have to be very careful that those patients do not have NTM, because the macrolide is an important part of the treatment of NTM. And again, if the patient can't take a macrolide and is having 2 or 3 exacerbations per year, we do think about a schedule of inhaled antibiotics. So to summarize, that was quick, but hopefully get my take-home messages here. I would say this: your management should be guideline-based. Your physician should have some familiarity with the guidelines, but then it needs to be individualized to you. I would recommend that an evaluation be done to make sure there's not a treatable underlying reason for you to have bronchiectasis. And if there is a treatable thing, then that should be treated. I think all patients should at least be aware of the option of airway clearance. And even if you don't use anything too cumbersome, I would again stress the value of deep breathing, huff coughing, and exercise. We should be careful about the routine use of drugs like Symbicort or Flovent, or there's a whole bunch of them that have inhaled steroids, because they can make your infections worse. If you are a frequent exacerbator, then the options are the azithromycin strategy or inhaled antibiotics. And then again, a couple of things to remember that should not be routinely used, and I'm saying it repeatedly: inhaled corticosteroid, oral steroids, oral prednisone should not be routine in this disease. Routine oral antibiotics, not a good strategy. And again, the macrolide by itself. Some patients benefit from having consideration for surgery to take out the worst area of disease. And I put this in here just to show you what a really badly damaged lobe looks like, with a lot of dilated airways here that will trap the mucus. And some other surgeries we think about, obviously, for the rare patient who has severe unrelenting disease, we think about transplantation. And the patient who's severely aspirating, we think about some sort of anti-reflux procedure. All right, so hopefully gotten the message. A lot of education for the patient, I think, is very important. You really want to know your bacteria that you have down there on a regular basis. I think it really helps to have that sort of mental image of your lungs, and so where to focus your airway clearance, and the importance of calling when you have an exacerbation, because prompt treatment means prompt improvement. What defines an exacerbation? It's generally increased cough, increased sputum production, a change in the color of the sputum, coughing up blood, sometimes having fever or increased shortness of breath. Those are the things should really prompt a call to your clinician. I'm going to just very briefly talk about drug trials in bronchiectasis. And I just wanted to walk you through for 5 minutes, how do we get to new drugs for any disease, but particularly for bronchiectasis? So, what happens first is that there's research and development either done in pharmaceutical companies or in NIH or other sponsored research labs. And if a drug is thought to be promising, there will be some preclinical research done, especially to look at toxicology, to see the drug is given to animals, to see if it causes any adverse effects. And then just to familiarize yourself with the terminology that we use in the FDA. This is straight off the FDA website on drug development and device development. The company or the sponsor of the new drug or the new device has to get what's called an IND from the FDA, Investigational New Drug Approval. And then the drugs go through phases, right? Phase 1 is a small study really to look at the safety and the dosing strategy for the new drug or device. Phase 2 is to look at the effectiveness of the drug and side effects in a relatively small number of patients for a relatively short period of time. And if those are successful, then the drug will potentially go to a phase 3 trial, which is a larger trial, can be over up to 3 years, and looking at the effectiveness and monitoring for adverse effects. Now, how many drugs start at the preclinical and make it through to approval after 3 phases? It's a very small percentage. And again, I pointed out to you that there's been a number of trials done like this in antibiotics, and they have not crossed the hurdle to be approved by the FDA. Once a drug is approved, then it gets a label that tells physicians who can be prescribed the medication. And there's what's called a phase 4 process done by the FDA, which is efficacy and safety post-marketing. So, I'm going to close by talking about the number of clinical trials that are going on right now, but just to get the verbiage down, often we ask patients to enroll in what we call a randomized, double-blind, placebo-controlled trial. So that means that patients are assigned to either an active drug or a placebo meaning something that tastes and smells like the active drug, but actually doesn't have any active drug. Double blind means that we investigators don't know which drug the individual research subject gets, and the patient doesn't know either. Sometimes studies have what's called an open label extension, in that everybody gets the active drug at the end of the study period. There are studies that are done which are open label, so we actually know what drug the patient is getting. And then, of course, patients have to fit into the protocol that's designed for the study. And I know Mary and I have talked about this over the years, how this can be very frustrating, that we're either lumping or splitting patients based on the cause of their bronchiectasis, or we're not defining the cause very well, and then kind of get mushy results at the end. Likewise, you have certain inclusion criteria for these trials, and then other patients are excluded because of various reasons, depending upon the study protocol. Just a few other words to know: when we do clinical trials, the protocol needs to be approved by what's called the Institutional Review Board, the IRB, and that can either be a central one or one at every institution who's involved in the trial. And the IRB is there to assure that the study is sensible and safe, and there to protect the patient volunteer who's enrolling in the trial. If a patient agrees to be in a trial, they get what's called an informed consent. It's a very detailed document explaining the risks of the trial, and then you undergo a screening visit. The FDA is very invested, I think, in our disease, and Amy and in the non-tuberculous mycobacterium. They've held a number of patient forums and trying to get things rolling forward so that we get some new trials or new drugs for bronchiectasis and for non-tuberculous mycobacterium. The FDA wants to see clinical outcomes, improve function for the patient, and reduce mortality. And again, that when we talk about clinical trials, there's always a primary endpoint. And usually in bronchiectasis, at least to date, that's been to reduce the flare-ups, to reduce the overall exacerbations, or to increase the time till the patient has the next flare-up. But we also do secondary outcomes, and importantly, these are things that matter to patients, right? In terms of feeling better, better function, you know, either as measured by questionnaires to assess quality of life, and also by looking at lung function, 6-minute walks. You know, you can't just kill the bacteria, right? You got to make the patient better. So a big focus is really to look at not just killing off bacteria, but to make the whole patient better in these clinical trials. And so just to let you know, I mean, I showed you the list of the inhaled antibiotics that have been looked at. I showed you that there has been positive results in studies on using azithromycin. But now we're into like new things, which is very exciting for patients and for us who've been involved with trying to find new therapeutics for bronchiectasis. So of course, we're still looking to target the bacteria in different ways, and talk about that in a second. But now there's a new focus of research and new drug development for bronchiectasis, and that's in targeting the inflammation. And people that have chronic bacterial infections in their lungs have a lot of neutrophils around that infection. Neutrophils are cells that are produced by the bone marrow and circulated through the blood, and they tend to rush to areas that have a lot of infection. So one new strategy is to look at inhibiting some of that neutrophil activity, which seems to, by inhibiting the neutrophil elastase that reduces the inflammation. So we have this drug, Bronchiectasis, I'll mention in a minute, and there's another trial about to open or just opening with another product, which is right now called BI 1291583. There's another type of inflammation that some patients with bronchiectasis have, which is eosinophilic, and eosinophils are another cell that's produced by the bone marrow and sent through the blood to areas of inflammation. We tend to think of eosinophils more as in asthma, but some patients with bronchiectasis have a lot of eosinophils in their lungs, and there is now interest in doing trials for that type of bronchiectasis. So just to leave you with a couple of updates, the latest trial that was presented just a couple of months ago is an old drug, inhaled Colistin. It's been repurposed and put into a special nebulizer. And the first part of the trial was presented earlier this year, and it showed reduced exacerbation, so a favorable result. And later this week in a meeting in Prague, the World Bronchiectasis Conference, some more data is going to be released. So this drug has some promise and may make it over the hurdle of showing efficacy. I mentioned Bronchiectasis. This is the phase 2 trial that was done and published in the New England Journal of Medicine that showed promise, increased the time to the first exacerbation. And now there's a phase 3 trial with a much larger population called the ASPEN study, which is underway to look at the effectiveness of this neutrophil elastase inhibitor. And these are a couple other trials right now that are apropos what I just said in terms of reducing inflammation. And I would be remiss if I didn't say one word about non-tuberculous mycobacterium. Of course, you've heard many presentations from NTMIR about this, but really the one breakthrough really has been in new drug development for MAC. I mean, we have a ways to go. There's more trials going on right now, as you can see here, but at least there's progress being made when patients have bronchiectasis and non-tuberculous mycobacterial infection. So I would close by saying it's very important that patients understand this sort of stepwise approach that should be based on the guidelines that we had, but individualized to the individual patient. You know, I'm repeating myself, but we're just not here to reduce your bacteria. We want you to improve your day-to-day quality of life and prevent the disease from getting worse. really advocate for clinical trials. I mean, this is the only way we're going to get new drugs, either repurposed old drugs or new ideas, new therapeutics, like I just mentioned. And your voices are so important to this. This is why it's so great. We have NTMIR and running on air to advocate for the patients, because what we're asking you to do in these treatments is often very cumbersome and takes a lot of time, and we still don't know all the answers here. So your voices are essential to moving this disease forward. So I thank you for your attention and anxious to hear the questions. So I'll stop my sharing. Yes.
Okay, thank you very much, Dr. O'Donnell. And I just want to remind everybody that Dr. O'Donnell is not able to give any specific answers to your particular situation, but we'll be answering questions more globally. So, Dr. O'Donnell, can you go over the list of what is considered an exacerbation again? And I'm going to throw in my own question with that, because I know the first one is usually said as an increased cough. So does a decrease in cough? So would it be a change in cough overall, either increasing or decreasing? And what are the other symptoms?
Right. So we have developed for research purposes a definition of exacerbation. And we used to say, it when you see it kind of thing, but we tried to make it more checkbox kind of thing. So I hear what you're saying, Mary. I mean, usually we're talking about increased cough, increased sputum production, a change in the color of the sputum. So if your sputum's normally clear and then it turns green or brown, that's one of the signs. Increased shortness of breath. For some patients, increased wheezing, like I mentioned, coughing up blood. And then for not everybody, but occasionally patients will run a fever. But I take your point. I mean, sometimes when you can't clear the sputum, like your cough goes down, that can also be a worrisome sign, and something to contact your clinician about.
All right, thank you. Let's see. Sorry, there's quite a few questions here. So you did talk about the trials that are out there right now. And the Bronchiectasis is currently enrolling people.
Yes, so there are a number of clinical trials on right now. I know somebody was asking in the chat, I see, or the Q&A. You can see the slides. I mentioned a few, but if you go to clinicaltrials.gov, which is a website from the US government, and you just type in bronchiectasis, and if you live in the US, confine it to US sites, it'll give you all the available trials that are enrolling and also the sites where they are. So it's a very helpful website.
Yeah, Amy, if you wouldn't mind, if you could post that link in the chat, that would be great.
And I know Helga and Amy, they have trials listed on the NTMIR website as well.
Will do.
Thanks. So for asthmatics with bronchiectasis, anti-inflammatory inhalers can be needed for asthma, but will they make the bronchiectasis worse?
Yeah, so you walk a thin line with the inhaled corticosteroids, so the asthma inhalers, that have steroid in them. There are clearly patients who need those with bronchiectasis. The risk is that those inhaled steroids do raise the infection potential in the airways. So my point really was that this should not be, not everyone needs to be on an inhaled corticosteroid. It really is a subset of patients. with a more asthmatic component to their disease.
And along those lines, with steroid inhalers, the use of prednisone,
Yeah,
and should that be a caution too?
yeah, again, that should not be a universally used therapy, even for an exacerbation. There are, again, some patients do need prednisone when they have a flare up because they're wheezy or tight. But you know, prednisone, as I'm sure people know, is a two-edged sword, right? It can help certain things, but it can also raise the infection profile. And certainly if you take it long-term, it has a lot of side effects, bone loss and elevated blood glucose among them.
All right. And someone was asking, they said they were on Trelegy and switched to Ellipta, and was wondering if Ellipta is a steroid.
Ellipta is actually the name of the device. There's a number of Elliptas. So Trelegy does have steroid in it and 2 bronchodilators, but there are other. Ellipta is like the name of the device.
Okay, Anoro?
Anoro, right. Anoro does not have steroid in it. It's 2
Okay.
bronchodilators. Yeah.
Okay, all right, thank you. What types of doctors should people with bronchiectasis be seeing?
I'm a little prejudiced because I'm a pulmonologist. But I think many patients, it depends, right? If you have and there's not that many of us bronchiectasis, quote unquote, experts, if you can access that kind of person, it's good. But some patients, depending upon where you are, need both a pulmonologist and an infectious disease physician. The pulmonologist, I think, should handle the airway clearance teaching and sort of, you know, other things that go along with clearing the lungs, and then sometimes need help from the infectious disease if there's a infection that's challenging to treat.
All right, there's a question about sputum production in terms of the sputum, I guess, like changing color throughout the day. So they say it's yellow in the morning, then changes to like white subsequent days, then yellow again. So when would that be a concern and contacting your doctor?
Yeah, again, I would see it as a combination of symptoms that makes you want to contact one of us in terms of, you know, I mean, we say like at least 3 or 4 symptoms. So not just change in sputum, but increased cough, you know, maybe having a fever, fatigue, chest pain, those kind of things. So if it's just a change in sputum and you don't have other symptoms, that doesn't necessarily constitute a exacerbation. I also want to say that along these lines, that's why I'm a big advocate for doing routine sputum surveillance cultures. So, you know, I often see patients every 3 or 6 months, and I try to get who are well, who are stable. I try to get a sputum culture from them at their routine visit. So, you know, we have a sense of what bacteria is there, and if they do flare up, what antibiotic I would use to treat it.
All right. So a question about Pseudomonas specifically. Somebody who heard you speak recently, they said with Drs. Daly and Albuterol.
Mm-hmm.
And so the question is about treating Pseudomonas.
Right. So that's a good question. I mean, there is a school of thought that if you have serial sputum cultures and all of a sudden your first one, you know, first isolation of Pseudomonas, that might, it might be worth trying to do what we call eradication strategy, like a very intensive course of antibiotics, usually an oral or an IV antibiotic plus an inhaled antibiotic for, you know, 6 to 12 weeks. At the time the first Pseudomonas shows up in your history of having sputum cultures. So that strategy, though, is often a challenge, right? Because if you don't know, most patients don't know exactly when the first time is that they've had Pseudomonas. And usually once you have Pseudomonas, it's actually very difficult, even if we try that strategy to eliminate it, so to speak. So there's a little fight going on among us bronchiectasis people about the value of that, trying to eradicate, because it's very difficult to actually accomplish that.
Okay. Is there a connection between Marfan syndrome and bronchiectasis?
Yes, Marfan's is very rare. There's been more connection between that, I would say, in the patients have bronchiectasis, but with non-tuberculous mycobacterial infections.
For somebody who travels, would you have specific recommendations? And I'll for somebody, say, who's more stable, or maybe would that be different if they had more exacerbations?
Yeah, so travel, that's a great question, right? Because it can be difficult to travel with all the airway clearance stuff that we sometimes recommend. So again, I go back to exercise, doing the huff coughing and stuff like that. You can certainly take a device like an Aerobica or a cappella with you on travel. For some patients who are very symptomatic and need to continue all of their therapies, they take their nebulizer in their vest if they're using that. But many patients can get away with using the lighter forms of airway clearance when they're traveling.
All right.
I'm seeing a couple of things that maybe I could address real quick in the questions.
Yeah.
I know somebody asked, what is TIW in macrolide therapy? It's 3 times a week. Sorry for using the shorthand there. 3 days a week, like Monday, Wednesday, Friday. There's another question about, is there any blood tests that we use like that indicate a coming exacerbation? The answer to that right now is no. But we're looking for that. A lot of investigators are now banking blood samples on patients who are having exacerbations, so see if we can find some kind of biomarker. And I know that questions about deep breathing, I would refer you to that bronchiectasis toolbox website to get the better ideas on that, examples.
Okay. So do all patients with NTM have bronchiectasis?
Yeah, most do, but not all. Some patients with NTM have underlying like COPD or emphysema, or they have like sarcoidosis, so fibrous fibrotic lung disease. But the vast majority of patients with NTM do have bronchiectasis as well.
Okay. With a heart condition, ventricular tachycardia, are the macrolides dangerous?
Yeah, we usually get an EKG before we start patient on a chronic macrolide to make sure they don't have something called QT prolongation, which is an electrical problem in the heart. Ventricular tachycardia, if that's a chronic problem, might be a relative reason not to take a macrolide. And there's a number of cardiac medications that people get on that don't work well with macrolides. They're contraindicated, so you have to be very careful about macrolide and that kind of thing.
A question regarding COVID. Have you seen any significant changes in long-term bronchiectasis or NTM patients after they have had COVID?
Yeah, fortunately, I have had patients, my bronchiectasis patients, get COVID. with really no significant consequences, no long-term. I mean, that's anecdotal, but actually our friend from Scotland, James Chalmers, has published a story, or I'm sorry, a publication on his Scottish experience with bronchiectasis and COVID, and found the same thing. It really wasn't a big issue. Part of it is because patients with bronchiectasis are usually, very compliant, wear their masks, socially distanced, et cetera, and are on guard for this. So that's the one good news about COVID in this.
All right. Just looking, we have a lot more questions.
Yeah, there's a
lot. What types of exercise are best for someone with bronchiectasis?
Again, anything is good. I don't think there's a particular exercise that, stands out in my mind.
I would say the best exercise is the one that you'll do.
Exactly. Yeah.
So question, you start with the list of causes of bronchiectasis, potential causes. You mentioned RA. Sorry, kind of jumped out of my.
Yeah, I mean, rheumatoid arthritis, Sjogren's syndrome, those are rare causes of bronchiectasis. I think the question was something about hereditary, but those are usually not hereditary.
Okay. All right.
I see there's another question about differentiating the eosinophilic versus other inflammation, neutrophilic inflammation. And the way right now that we're doing that is blood tests. So if you have elevated eosinophils in your blood, that should be something that raises the question of eosinophilic inflammation.
All right. Questions regarding sputum production. So I'm going to kind of combine these. Despite daily use of saline, Vest, Aerobica, I'm unable to bring up any sputum. Any suggestions? I hydrate with a glass of water in advance. And if a patient is unable to cough up enough sputum to be tested for bacteria, are there other ways to test sputum? What would you recommend?
Yeah, so it's good what you're doing in terms of usually what we call a sputum induction is done with the hypertonic saline, so the 7% saline from the nebulizer, and that often works, but sometimes doesn't. Unfortunately, the next step up is a bronchoscopy, which, in most patients is not needed, but occasionally is. But obviously, we're not going to do bronchoscopies every 3 months to get sputums. So, the airway clearance is usually the way we go.
How can we find out the type of inflammation we have?
Yeah, again, doing a blood test to look for eosinophils right now is the way to go. In research trials, it's been looked at like in the sputum, are there a lot of neutrophils or a lot of eosinophils? But that's not ready yet for clinical practice. It's still being looked at in research setting. So right now it's really the blood test, the CBC blood test, which is the complete blood count.
So there was a question that when you were talking about airway clearance, you stated know where you should be targeting your airway clearance. And the person was asking, are you referring to a specific lobe of the lung?
Yeah, I mean, for some patients who do have focal or, one lobe with bronchiectasis, I do recommend, targeting the airway clearance at that lobe. You know, if your disease is more in your lower lobes than your upper lobes, I think again, targeting the lower lobes is helpful. So that's what I meant by that, kind of having a mental image of where your disease is. You know, many patients have it in all 5 lobes of the lung, 3 on the right, 2 on the left, but some are focal, and that's can be targeted.
All right. I just want to check in with Amy because we're at a minute after 3. We still have a lot of questions. So,
Yeah, no, it's as long as you and Dr. O'Donnell can keep going, we're still good to go.
Okay.
all right. So Dr. O'Donnell, are you good for a few more?
Yes. Yes.
Okay. So somebody asked if there is a way to keep from getting Pseudomonas.
Yeah, and there is not. We don't have a vaccination against Pseudomonas. Unfortunately, there isn't a way to get it, to avoid getting it. I mean, not everybody has it, but only about 1/3 of patients with bronchiectasis have it. But right now, there's no way to prevent it in an individual patient. I see a question that comes up fairly frequently is, you know, when you do have these bacteria and they're sent to the lab, and, you know, then the lab does the antibiotic susceptibility testing on the sputum. And what if the bug is resistant, right? So we think that if you're on an inhaled antibiotic, that resistance probably doesn't matter because you're putting so much drug right into the lung by inhaling it, but it probably does matter somewhat if you're taking an oral drug for the Pseudomonas.
Okay. So another question about Pseudomonas. If one tests positive for Pseudomonas a few times, but not always, is the bug always there, just not active?
Yeah, I mean, this is the limitation of the testing that we do, right? And it also is somewhat a limitation of the lab. So once you have Pseudomonas, again, it's probably always there in some amount. But because we're testing sputum that comes up through your mouth, and you know, it may have other bugs, that one might win out, if you will, on the lab testing on a certain day over another. I know that sounds kind of crazy, but that is more or less the truth to that.
Let's see.
I see there's some questions about phage therapy, which is something where I didn't mention, but is phages are not antibiotics. I mean, they're viruses actually that work on killing certain bacteria. And there's been a what we call observational publications, like small numbers of patients who have received phage therapy, either inhaled or IV for refractory or, you know, infections that have not responded to any other therapy. There will probably be some clinical trials of phages in the relatively near future. I mean, phages are actually, they're in the environment, they're come out of sewage and things like that. It's a complicated way they get put into the human, but we're not, we're a ways away from knowing whether phages are really effective other than these one-off cases.
There's a question about potential future use of stem cell therapy.
Yeah, you know, there was somebody trying to look at that, but that's fallen by the wayside as far as I know. So there's no trials right now for that. Not sure where that's going to go.
Any use with lavage to partially clean a lung?
Yeah, that's a good question that I hear a lot too. I mean, I you know, a one-off bronchoscopy to rinse out the lungs, right? It sounds like a good idea, but honestly, I would not recommend it. It tends to stir up the inflammation. and the mucus just fills right back up as the bronchoscope is removed. So in my mind, that is not a strategy that's effective for this disease.
Is bronchiectasis linked to heart disease or tachycardia?
People with bronchiectasis, when you're symptomatic, of course, it can, demand more from their heart. And so you can have a raised heart rate with bronchiectasis. There's not a direct relationship, though, between heart disease and bronchiectasis or vice versa. So no.
Let's see. All right, here's a question. Somebody who sounds like they've been colonized with Pseudomonas for 25 years, and now their culture is growing a new bacteria.
Yeah, I see that there's also questions about Stenotrophomonas, which is kind of a cousin of Pseudomonas, but often does show up, or we're seeing more of that, and I see a question about Achromobacter, and there's other, we lump those bacteria as gram-negative bacteria. So it's not unusual to have Pseudomonas for a long time, and then all of a sudden Stenotrophomonas shows up, or Achromobacter or Acinetobacter. The struggle is getting a good antibiotic for those. It becomes more challenging to pick an antibiotic for those infections, particularly for Stenotrophomonas, because it has a very limited repertoire of antibiotics that work against it. So we need more research. We've done a fair amount of research in chronic Pseudomonas infection, but the research is relatively lacking with the other bacteria, particularly with regards to antibiotics. Now, this Bronchiectasis trial is, as we say, agnostic for bacteria. You don't have to have a certain bacteria to get into that trial. So, taking a different approach other than antibiotics, hopefully we'll have some positive results as time goes by. I know somebody asked how long is it going to take? As I pointed out in that review of the FDA process for getting a drug from drug discovery to actually be on the market, I mean, it's many, many years. Usually the whole process is usually about 10 years. So even a drug right now in phase 3 trial, all the patients have to be enrolled, all the 1 year data has to be accomplished. So Bronchiectasis, if it's going to be successful, is several years away from getting approved.
Yeah, and the phase 3 is currently still enrolling, and it's been enrolling for around a year now.
Right.
Yeah, I am in that trial and about to wrap up
To finish,
my 1 year.
Yeah.
Yeah. So a question about the bacteria. Would you treat that right away just because it cultured, or would you only treat it if there were worsening of symptoms?
Yeah, no, that's another great question, right? I mean, it is kind of a individualized decision. One of the challenges here is that, as opposed to, say, cystic fibrosis bronchiectasis, where most patients are diagnosed in childhood, infancy, childhood, and they're followed serially, and how their cultures evolve. When we see a patient with bronchiectasis, it's not like I have 10 years of prior cultures in most patients to know when they first developed Pseudomonas or staph or whatever particular bacteria. So in my mind, this is when I go, opt to put patients on, say, chronic antibiotics, inhaled antibiotics, it's a shared decision with the patient, and it really has to do with the whole picture of the patient, not just the culture.
So the person who asked the question about RA kind of clarified. So they had a parent who had severe RA, and I guess they don't, the patient doesn't have RA, but does have bronchiectasis. And they were wondering if there could be a correlation.
Yeah, no, that's an interesting question. I don't think there would be. There may be some other underlying hereditary thing. But no, I wouldn't see that connection like that.
Okay. What causes a mucus plug, and is there a way to clear it?
Yeah, I mean, some people have particularly thick mucus, and again, we go with the airway clearance. If people are very pluggy, using the hypertonic saline probably has some advantage there. If patients, another thing to think about, I mean, sometimes patients who are really produce a lot of plugs should be looked at for the disease called allergic bronchopulmonary aspergillosis, because those patients tend to put out a lot of pluggy, pebbly type sputum. I see there's a question about NTM versus Pseudomonas. Need to make that clear, right? That when we look at the sputum, right, in general, we're asking the patient to do a culture for the routine bacteria, and that would include Pseudomonas, Haemophilus. I mean, they look for all types of routine bacteria. And then, so when you give a sputum specimen to the lab, in general, you have an order for the lab to do a routine culture, but also an AFB culture, a mycobacterial culture. It's two separate processes in the lab. The lab takes your sputum and divides it and puts it into one type of culture media to check for the regular bacteria, and another type of culture media to check for the non-tuberculous bacteria. Now, the lab has to get the request in that way, but it's separate laboratory processes to look for the NTM versus the regular bacteria.
All right. So there's a couple questions going back to how to target airway clearance to a certain area of the lung.
Yeah, I don't want to leave you with the idea that this is a common thing. I mean, using the two-person cupping and clapping and postural might have a role if there's one area that's particularly affected. But everything else that you do, like the aerobica or the saline, that really is non-targeted. So the only way you could do in my mind, targeting a particular area is to do the cupping and clapping and postural drainage. But I don't want people to leave with the idea that that's like a common scenario. Usually we're talking about both lungs.
Yeah, and I'll just add, as a bronchiectasis patient, I can feel a lot tighter or more congestion, say, in my left side. So I'll frequently, if I'm having trouble clearing, ask my husband to, do a little postural drainage on that side. So I don't go through the whole routine, but that definitely helps, I feel, move the sputum out of that one side. So question about using albuterol prior to the hypertonic saline or just saline. So it says,
yeah, right. It's a good question, right? How to sequence these inhaled therapies, and there's some recommendations that come out of the CF Foundation, but usually we will use, I mean, many patients do use a bronchodilator like albuterol prior to the saline. That's mainly to prevent like a lot of irritation from the saline. In my experience, and Mary, you can chime in about this, I mean, many patients don't need to use albuterol unless they're kind of a wheezy patient. But if you're going to do the sequence, right, you should do albuterol, saline, and then the inhaled antibiotic.
Yeah, and And I'll say that my sister, when she was using it, she would do like half of the albuterol, do the saline, and then do the other half of the albuterol. And she found that really helped, her not to be too bronchospastic. And then part of the question, so I just want to clarify that albuterol and saline are not steroids.
Yes, albuterol is a short-acting bronchodilator, and saline is just salt water.
All right, Dr. O'Donnell, I just want to check in with you again. We're at a 16 after.
I know there's so many questions and we don't have all the answers. And one thing I am seeing quite a bit about the defining an exacerbation. I can certainly, send that to Amy and Mary, and you can post it. There, again, we have had a consensus group of us, many of us from the US and Europe, that came up with this definition. So happy we can circulate that.
Yeah, and I think this goes to show that we need to have you back.
Well, we're thinking about how we can do more, with not just me, but many other of our colleagues. Because the more, it's hard, right? I mean, it's hard. Every patient is unique and needs personalization of their care. So
yeah. Yeah, so Amy, I don't know if there's a way of like capturing the questions.
Yeah, so we're going to go ahead and capture the questions and both in the Q&A and the chat. So if we have others that need to be answered, we will try and get those answers. And Dr. O'Donnell, we're happy to have you back anytime. So maybe we should have another webinar.
Yeah.
Yeah, we can, I think the airway clearance thing is such a challenge for patients to really get clued in on, right? I know, Amy, you've done other ones on that, but that is a big challenge for patients to learn about, because unfortunately most physicians don't have trainers in their office to teach this stuff, so it's important. Wow, there's a lot of messages here.
Yes, there are a lot of thank yous. A lot of thank yous. Thank you again for joining us today. This, I think, was very informative. As I said, we have a limited amount of time to talk about everything that comes up. So yeah, I'm guessing that we can either do another webinar or some kind of AMA at some time.
Yeah.
Get more questions answered. Everybody, thank you so much for joining us today. We were really delighted to have everyone. We will do everything we can to get all of these questions answered. We're going to go ahead and capture them now.
And Amy, if I can just give another shout out, Friday is World Bronchiectasis Day. We're trying to raise awareness of World Bronchiectasis. So if you are on social media and don't mind posting on your personal page, just today is hashtag World Bronchiectasis Day and hashtag I have bronchiectasis. And you can also put what caused your bronchiectasis, but just a way of getting World Bronchiectasis Day trending and raising awareness.
Thanks, Amy and Mary. This was a wonderful opportunity, and I appreciate being asked to be part of this. Thank you.
Thank you again. We were really happy to have you, and like I said, I have a feeling you'll be back.
All right. Thank you very much.
All right, everybody have a wonderful week, and don't forget Friday to put the word out about World Bronchiectasis Day.
Thank you, everyone. Thank you, Dr. O'Donnell.
Thank you.
And thank you, Amy and Helga.
Yeah, thanks.
Thank you, Mary, for putting this together. It was a wonderful webinar, and we look forward to others in the future, probably very soon, judging for that are coming up.
All right. Thank you again.
Thank you.